following session, and now scanning them again, they have even a tighter stenosis after this. So maybe there was some hypoplasia here, but this is the type of study we would really like to correlate. Do people get better? Does the flow improve? If people get worse, has the flow become bad? This is an example of quantified flow before and after treatment. Here we have two of the jugulars with a flow of roughly 2 and 6 milliliters per second. After treatment, the 2 has become 4 milliliters per second, and the 6 has become about 7 milliliters per second. So we can see a clear improvement in the flow in this individual. And of course, this is objective in terms of its capability. Now, again, I don't want to spend too much time on this, but I want to point out to you that if we take the flow for all the vessels and normalize it to the total arterial flow, we can get basically a percentage. So we can say, for example, the left common carotid artery divided by the total arterial flow is about 40% of the flow in a group of patients who have no stenosis. And if I take the group of patients who show stenosis, again, on the arterial side, it's almost the same number. And what we found is when we broke the data up for the study with David Hubbard, that we could separate out 2 types of MS people. Those who seemed to show clear stenosis and those who didn't. And yet, on the arterial side, I see no difference. What about on the venous side? If I look at the internal jugular venous flow, I find out on most people who have no stenosis that they carry about 75% of the flow, but only 60% in those people who show stenosis. So I'm going to skip through here. And perhaps these are the most important quantitative slides of what I'm going to show you here. So what I want to tell you at the beginning is there's a nice study by a fellow named Duck from 2004, I believe, in neuroradiology, who said that he would evaluate the flow, the normalized flow to the arterial flow in 50 people. And he found that 72% of those people had most of the blood carried by the internal jugular vein. So let's call that the upper third. 2/3 to 100% of the blood flow is carried out by the internal jugular vein. Only 22% had that 1/3 to 2/3 carried out by the internal jugular vein, and only 8% had a very low flow in the internal jugular vein. So again, if I take those people who had just no clear stenosis and knowing nothing about their flow yet, and then go and evaluate their flow, lo and behold, in the data from David's case, we found 70.5% fit that criteria of having most of the blood flow carried by the internal jugular veins. At another site, also with 100 cases, we found the same number when we divided that up into stenotic MS patients and non-stenotic MS patients. And you can see the type 2 was 30% in both, and we didn't actually find anything in type 3 in that particular subpopulation. Now look what happens when we go to the MS patients that show clear stenosis. Oh my heavens, they don't look normal at all. So perhaps outside of Zamboni's work, this may be some of the first data to show clearly in 200 cases at 2 different sites with 2 different MR magnets, both normalized the same way we normalize ultrasound data, that there is a clear reduction in the distribution of flow in multiple sclerosis patients. That most of them now are fitting into the type 2 category, and more in the type 3 category. A much smaller fraction fit into this normal category than in most people. Most of the blood flow is carried out by the internal jugular veins. So if this is true, one of the most important questions for us to ask now would be, could we compare the improvements in the patient's cognitive scores, motor scores, and other methods that David and others are doing now, such as MSIS-29, and could we show that maybe most of the people who are recovering are those that have the severe stenosis? And the ones that aren't recovering the most aren't recovering because they don't really have this major flow deficit associated with them? Okay, we don't know the answer to that yet. It will wait until David unblinds me, because the nice thing is I'm completely blinded on this data. I have no biases here whatsoever. So until David does unblind me, I won't be able to separate these out. Now maybe we'll find out that the people who are stenotic tend to get better. And maybe we won't, because as has been pointed out by Don and Mike, that there are also valvular problems, and I can't measure those valvular problems with MR yet. So I'm just going to show you briefly the following picture. This is a plot of the dominant flow versus the subdominant flow. So for example, if somebody has 8 milliliters per second in the dominant jugular and only 1 here, he has an 8-to-1 ratio, which is probably not a good thing. So I'm just going to break this up a little bit and show all the people who have blood flow less than 8 milliliters per second in the internal jugulars. Okay, all of these triangles and squares that are colored in red and blue are the people who have stenosis. Now let's look at this. All the people who have flow in the subdominant vein less than 3 milliliters per second, they're mostly people who have stenosis. And finally, all of the people who have this rather high ratio of greater than 3-to-1 of one jugular versus another, shown in purple, they're mostly the people with stenosis, which just leaves this little group up here are the ones that don't have stenosis. So hopefully we can add a third dimension to this, which is the measure of improvement of the patient's condition. So finally, what about the role of CCSVI in other diseases? Well, in intracranial hypertension, usually you have some stenosis in the transverse sinus or sigmoid sinus. But this individual, you can see here, has some abnormalities in the left internal jugular vein. You can barely see it here. It's very narrow here. This is another view of it just to show you how narrow this is. And of course, the neurologist said to me, this patient does not have MS. He just has intracranial hypertension. And of course, they have to drain CSF from this person to relieve that hypertension in some cases. So we scanned him again, and we find he has his first lesion associated with this. Now, maybe not all intracranial hypertension cases have bad jugulars also, but the neurologist constantly asks, well, how come we don't see MS with intracranial hypertension? Here's your first case. Why? Because maybe we didn't look for it before. Maybe we haven't been paying enough attention. And in this case, similar to the other cases I showed you, the flow dominated by one internal jugular vein. Now, this is a very interesting case. Here you can see something like this truncular venous malformation with a thin strip coming down here on the left internal jugular. You can see for the first time, actually, a stenosis in the external jugular, which we usually don't see. Again, dominated by one major vein. But wait a minute. This is a Parkinson's case. This is not a multiple sclerosis case. So there's 3 such cases now that I'm aware of in the world. This is the only case that I've been involved with. Here's the flare data on this patient 5 years ago, and there are hints that this patient has white matter lesions. Here's this data today. Gee, you just might think this is an MS patient. So now we're starting to cross over this boundary a little bit. How important is CCSVI to neurological disease? Why does Ivanov see CCSVI in other neurological diseases? Maybe it plays a role in other neurological diseases as well. So in conclusion, I think it's very important that we monitor lesions and iron content for all patients. I think, personally, I don't think this is the right thing to do for interventionalists not to get people imaged. Because the neurologists, on one hand, they want to see their patient's image. If I were a patient, I would want my baseline study, because what happens if after treatment, I do have a problem? I want to know what I looked like before I got treatment. If you don't scan these people before treatment, you won't know what happened to them from before and after. The 3D data helps us to do treatment planning. We can categorize now the different types of MS population by including things like iron, anatomy, blood flow, and this can serve, of course, as a baseline for the patients. I think one of the most important things, and I'd like to just mention this as a possible project here, I'm going to call it the Millennium Project. We need to collect 1,000 normal people. The only thing that I can see that the neurologist could object against right now, given the evidence that I've just showed you in addition to other people's work, is where are your normal MRI cases to compare with the MS cases? So I'm hoping we can start some project here to collect 1,000 normals. Because once we have that data for 1,000 normals, then we'll be able to definitively show that normal people do not have these problems, or at least not to the same level. So maybe one way would be to have, when patients get scanned, we have their skull scanned. To do that, we have to get Institutional Review Board approval, but I think we can do this and create a study. So any people, professionals in the group who would like to participate in this, I think we should get together and do this. So in conclusion, the MS population can be broken into at least 2 types. And I think once we start understanding that, we'll be breaking it into 4 types and 10 types. Patients must be imaged before and after treatment. We need to create a database, a worldwide database, to evaluate everything here: ultrasound, MR, angiography, venous angiography. And of course the treatment that David's already started that to image the cognitive effects of patients before and after. And we need to image as many normals as possible. So I just want to close here by mentioning that we're going to have the International Society for Neurovascular Disease in February 18th to the 22nd in Orlando. And I want to just mention to you, we're going to have Zamboni start this off on a Saturday, Sunday session all about imaging. And Robert Zbanoff's the president there. And we're going to have all sorts of sessions here related to perfusion, hypoxia, ischemia, abnormal venous flow. 2 different sessions on this. A special session related to the MS societies, where they have 7 people doing studies. We'll invite them to come and present. Sessions on hypertension, for example. And I don't know what hypertension is, but I must have forgotten to believe that. Flows on flow and computational fluid dynamics, where we have one of the leaders in the world coming to speak about this. So we're very excited about this possibility, and I think thanks to the effort by many people in this room, CCSVI has come a long way. We probably have more questions to answer at this point than we did a year ago, but we have direction. Thanks very much.